Good evening, everyone. How are you doing? Yes, fine. Okay, so this is the third class in this series. And if you remember, the previous one was a bit bad. I call it bad class. And it probably gave you some headaches, I don't know. But today's class will be much better, simply because it's easy and I think you will love it. I may try to keep this pattern, bad class, good class, and so on and so forth. And I don't know if you have noticed the background music that just finished is called Shahrazad Symphony. And if you know this symphony, it's a reminder of the vibe of telling a story. So in this class, at some point, I will ask you to imagine that we are telling a story about some sensory changes that will happen when there is a squint or with the onset of the squint. All right? So have fun. And see the next slide. I always stress on the importance of watching the previous classes. So whenever we have like a series, so in this series, the Strabismus illustrated animated series, you can't jump into the third class, for example. You have to watch the previous one because they are like building blocks. Imagine if you are building a tower or any building, you have to have a foundation like a base and then floors, next floor, and so on and so forth. Try to keep this advice in your mind and try to watch the previous class first before you watch this class, for example. I created a playlist regarding this series, so I will add future classes on this playlist. And remember, this series is all about understanding. We have to learn some basic concepts. These concepts are very helpful for residents, but sometimes for us as advanced learner, sometimes we forget some basics. And some basic questions do appear in the exam. And as you know, if you did a mistake in a basic question, this detrimentally affect your score too much. And even for practice. So in practice, sometimes we get cases of like classic cases. It's all about basic understanding. But unfortunately, sometimes teaching basics takes time and it needs a lot of patience. I have some warm-up slides before I start the main topic for today's class. As usual, I have some quiz questions for you. So in this quiz question, you have to fill in the gaps. On this chat, please write down the keywords to fill in the gaps. And here's some information about this case. This is just a test of your memory or test your knowledge about the previous class. So as you see, there is a photo of a girl. She's wearing glasses. So this is a question to fill in the gaps. Hirschberg test shows what, due to what, giving a girl a pseudo what. The Hirschberg reflex or the Hirschberg test shows decentration. You have to specify which kind of decentration. It's not centered in this case, it's decentered, okay? It's decentered. But it's not enough to say decentered. You need to decentered temporally, all right? So temporal decentration. So this is number one. Again, if you notice, the reflex here is a little bit decentered temporally in this eye and also in the left eye decentered a little bit temporally. So this is number one. Due to, yeah, exactly, due to negative angle kappa. All right. Giving the girl a pseudo what? When the reflex is decentered temporally, giving the girl a pseudo, which kind of squint? Yeah, so pseudo esotropia. So you have to say, as I said right now, it's not enough to say the reflex is decentered. Okay, you have to say decentered nasally, temporally, up or down. So you have to specify the direction. And you have to specify which eye or in both eyes. So this is like a practice to give the examiner a full answer. Don't give a drop-by-drop answer, in missing information. So you are, maybe you say decentered, then the examiner will ask you decentered where, nasally or temporally. So you have to say decentered temporally, and you have to say in each eye, in this photo, in each eye. Sometimes you may have like a decentered reflex in only one eye, so you have to specify which eye, okay? So this is number one. So again, the Hirschberg reflex or test shows temporal decentration in the right eye and on the left eye, okay? Due to negative angle kappa in each eye, giving the girl a pseudo-esotropia, okay? Coming now to, all right, negative angle kappa, all right, and pseudo-esotropia. This comes with what? Which error of refraction? Myopia or hyperopia? So you have to say high axial myopia. Someone said index myopia. No, no, no. The abnormalities of angle kappa is all about axial refractive errors and not index refractive error or like curvature refractive errors. If you remember in the previous class, I was stressing on this point. We may expect abnormal angle kappa with high axial errors. Okay, so you have to change the word index to axial. Okay. See, just a simple question, like straightforward question. And, you know, I got many confusing answers, like opposing answers. If you just read the information, the Rx here for refraction. So she has a refractive error of -13. Her glasses is -13 diopter in each lens, okay? So, and if you noticed, you know, in minus lenses are thicker at the periphery. So if you can appreciate from the photo, it is thicker at the periphery, and it gives also the eye minifying appearance because minus lens minify the eyes behind the lens. And now it's also written here because she has a myopic refraction. And because we are talking about axial myopia, I wrote down the axial lens. The approximate axial lens was measured by eye master. It's like 27 millimeter in each eye. She has a high axial myopia. Somehow she has a good vision, but here I wrote to make it simple, like 6/6 vision, best corrected, of course, by glasses. Okay, and here are some additional information. So Hirschberg test, you just answered it. And in order to diagnose abnormal angle kappa, it's not enough to do Hirschberg test, because simply Hirschberg test could be decentered in squint. This is the primary function of Hirschberg test. So we need to do cover test, a second step. If the problem is only abnormal angle kappa, the cover test should be negative. It should show orthophoria or orthotropia, okay? And there is another step in order also to diagnose angle kappa called visioscopy. I'm not going to talk about visioscopy right now, but I am just trying to show you that there are three steps in order to diagnose abnormal angle kappa. First, we will notice decentration by Hirschberg test. Then we will do cover test to exclude strabismus. And finally, we need to do something called visioscopy to document foveal fixation, because this girl has foveal fixation. She is using her fovea in each eye for fixation. Okay, clear now? Shall we move to the next slide? Okay, so by the way, there is no need to say sorry to the examiner, all right? Because most of the time when you say sorry whenever you said something wrong to the examiner, it might be interpreted as like you are begging for the mercy from the examiner, you are servile somehow. So there is no need to say sorry whenever you did a mistake from the exam point of view. But you have to say sorry to the patient if you did any harm to the patient or even discomfort to the patient. Okay, so this is my message right now regarding the word sorry. Okay, I know it's somehow like reflex. Whenever you say something sorry, something wrong, you say sorry, but don't overuse the word sorry to the examiner. Okay. This slide was taken from the previous class. I just added some additional information. Okay, don't expect that all cases with high axial myopia will have like negative angle kappa. It can, but it's not for every case. Okay, and I also added that high axial myopia can cause also abnormally small angle kappa, like 2 degrees, 1 degree. Okay, so you know the average angle kappa is positive 5 degrees. So some cases of high axial myopia could have abnormal small angle kappa. Some may have negative angle kappa. and some may have normal, like angle kappa with centered reflex, okay? So there are a lot of varieties. And on the other hand, high axial
hyperopia
can, so I added the word can cause abnormal large positive angle, or maybe normal, okay? So it's not a rule. One more thing about this slide. So whenever we ask some students, high axial myopia cause large angle kappa or small, they usually say large. They usually say large because they think that myopia is a large globe, like big globe, so the angle should be large. But as you know from the previous class, actually high axial myopia can cause abnormal small angle and even negative, okay? Again, they are also, most of them, confused. They think that hyperopia is a small eye, so the angle should be small. No, it's not that. The angle is abnormally large, positive, all right? And I think Dr. Ralia among us today, so she said a nice mnemonics. So remember, myopia is corrected by minus glasses, so you can remember we have something negative, okay? And hyperopia corrected by plus glasses or plus lenses, so we have large abnormal large positive angle. So try to memorize this statement because it's fundamental. All right. So if you remember, the previous class was all about angle kappa. By the way, it's the 10th letter in Greek alphabet. All right. So the most important significance of angle kappa is for strabismologists, those who are dealing with strabismus, okay? Because sometimes the case has like abnormal angle kappa and you misdiagnose the case as squint, but actually there is no squint. It's all about abnormal angle kappa. So it's really important to differentiate between pseudo strabismus due to abnormal angle kappa and true strabismus. And sometimes, by the way, they are both coexist in one case. But there is another clinical applications for angle kappa. It's also important in another specialty. So does anyone know what the other importance of angle kappa other than the field of excellence? So excellent, Dr. Asad. So he said refractive surgery. So it could be cornea at the level of the cornea, or it could be lenticular, to be specific, multifocal intraocular lenses, okay? And there are a number of papers if you are interested, but anyhow, for any refractive surgeon, you have to keep in mind the angle kappa, especially with multifocal IOLs, because you want to center the IOL on the angle kappa and not on the center of the pupil. So this is like a recent paper, like last year, about different machines that might help to measure the angle kappa, but they measure the angle kappa indirectly, okay? And this paper is like a comparison about different modalities, different machines for measuring the angle kappa, okay? So it has some role in refractive surgery in order to avoid decentered ablation zone and so on. So now if I ask you, and I posted this question before on the WhatsApp, so what are the causes of decentered Hirschberg test or Hirschberg reflex? I know you answered it, but please answer it again because I want to stress on another point. If you do the Hirschberg test and you found decentered reflex in one or both eyes, what could be the reasons or causes? So I just wanted to stress about the order. So say strabismus first, because Hirschberg is primarily used to assess and to screen for the presence of strabismus, like true strabismus, okay? So cause of decentered Hirschberg reflex is strabismus, and to be specific, you have to say like manifest strabismus. So I can write it down here, like it should be like manifest. Because, you know, and if we have like a latent strabismus, the Hirschberg reflex is central. But decentered Hirschberg reflex is a manifest strabismus at this point and at this distance, okay? And the second is abnormal angle kappa. Don't say pseudo esotropia or pseudo exotropia, because we have when it comes to pseudostrabismus, we have a causes. We have a causes for pseudostrabismus. For example, we have epicanthus fold for pseudoesotropia, but epicanthus fold doesn't lead to decentered Hirschberg reflex. So you have to be specific. You can say pseudostrabismus secondary to abnormal angle kappa. So I can write it down here. So here manifest, and here pseudo strabismus secondary to abnormal angle kappa. Okay. By the way, what is the other name for manifest strabismus? Hypotropia. All right. So this is the benefit of asking and waiting for your answer and answering, because we can refine your answers. And by giving you like answers like this, I can also refine my way of teaching, okay, to try to make some confusing points clear. So it's very good to have incorrect answers sometimes, because we can, as educators, refine our technique for teaching. And for you as a learners right now, you can learn from your mistakes, okay? I'm going to erase all this writing right now, but at least you got the message of additional points regarding strabismus should be manifest, like heterotropia, and we have to say abnormal angle kappa causing pseudo strabismus. But pseudostrabismus as a word is not enough, because we have other causes for pseudostrabismus with centered Hirschberg reflex, like epicanthus, like large interpupillar distance, giving a pseudo-exotropia, for example. Okay? Got it? But if we have like cases like this, what I mean by cases like this, like we have in this eye, left eye, nasal decentration or in the left eye, but it's like marked, okay? So this is for sure a case of exotropia. I know we need to do cover test, but it's very hard to get like an abnormal angle kappa, okay? Like large positive angle kappa, because you know in large angle kappa we have like decentration nasally, all right? So don't say supposedly you are giving a case like this or a photo like this in exam, don't say it may be like pseudo exotropia. No, it's very hard to get pseudo to that degree, okay? But you have to say to examiner there is exotropia of the left eye, and I have to confirm by cover test, because cover test is the mainstay for confirming the presence of strabismus, okay? So cover test can rule in or rule out the presence of strabismus. So don't say here the Hirschberg is decentered nasally, so it could be true strabismus or pseudostrabismus and so on. No, you have to say this is a true exotropia in the left eye, and I have to confirm by cover test. Here in the photo in the middle, it's very evident this is a case of esotropia of the right eye. Don't say this is like negative angle kappa. No, because here the decentration is very marked, and you can't see the nasal scleral triangle. This is definitely right esotropia, and you need to confirm by cover test. And here in this photo, there is decentration of the reflex lower. So I didn't mention this, but sometimes abnormal angle kappa could be like above or below, but this is very rare cases. So whenever we have like decentration like vertical, generally this is a squint, okay? So don't say abnormal angle kappa, especially on vertical decentration. So here the reflex is decentered lower, so we have a hypertropia on the left eye. And if you notice, there is a red spot because I photographed this case after doing force reduction test. Okay, so when we see marked decentration in Hirschberg or like a vertical decentration, don't say abnormal angle kappa in your differential. Say it's a strabismus, it's a manifest strabismus, and you have to specify which type of strabismus, XT or exotropia or esotropia or hypertropia or hypotropia, And you have to add to the examiner, I need to do cover test to confirm its presence. Yes. As an active member, she said also the degrees, because one of the other additional advantage of Hirschberg test, again, rough estimate of the angle. So according to the decentration, we may have an idea about the angle of strabismus, and I will cover this hopefully in the strabismus classes. And as you know, we have today another deal. If you remember, in the previous class, we had a deal, and today we have also a deal. And I'm expecting to agree on this deal, okay? So what is the deal for today's class? I'm sure that you forgot the title of today's class, by the way, but the class will be about the sensory changes, some phenomena, visual phenomena that arise with the onset of strabismus, with the onset of squint. So you know, we are going to talk about diplopia, mainly about diplopia. So in order to illustrate diplopic image, we have to have a target. So that's why my deal today for today's class is all my illustrations are at near, because if you remember, from optical point of view, we draw objects only when we are viewing at near. But if we are looking at distance, from optics point of view, we don't draw a target, okay? But since we are going to discuss about the diplopia and there must be a target in my illustrations, so all the illustrations are at near, okay? Now we have a near target. Let's say this is an apple, okay? And as you can see, both eyes are converging. And so we have the visual axis of this eye, of the left eye, and here the visual axis of the right eye, converging and intersecting at the object of fixation. So here there are some terms. You have to be familiar of some terms that strabismologists use, like in everyday clinic. So when we are fixating on a target, this is called the object of regard, or we can say the object of fixation or the point of fixation, okay? And here I wrote in the physical space, because imagine now we have an apple in front of you, okay? So the apple is present in the physical space, okay? Both eyes should be converging. So this is a normal alignment at near. So the visual axis should be converging and intersecting at the point of fixation. So this is what I said before in the first class, if you remember. And because this is a normal alignment, so we have an image for this apple on the fovea on this eye and on the fovea of the other eye. This is the right eye, and this is the left eye. And I draw here the apple inverted to remind you of the inverted image in physiology. So we have an inverted image here, inverted image here. And this is the asterisk, represents the fovea in each eye, and F for fovea, okay? And we have retinal image. This is the retinal image, and this is the retinal image. And of course, it is magnified. The image on each fovea represents this object. They are similar, okay? And the images will be processed to the brain, okay? And the brain will combine these two images into a single image, okay? So this person will perceive this object as a single object in the visual space, okay? So we have something called physical space and visual space. When I say visual space, I'm talking right now about what the person would see, okay? And one another term, an important one, the fovea here and the fovea here are called corresponding retinal points, okay? There is some term called correspondence. So every point on the retina here has a corresponding point on the other eye, on the other retina, okay? So normally both fovea should be corresponding points, but this could be applied in every point in the retina. I know it's the basics, but it's really important in order to move on. The brain receives the image falling on the fovea. It's perceived as, so we have something called the visual direction. So once the image the retinal image is falling on the fovea, this means that the object is central. So what's the meaning of central? It means that this object is like centered in front of both eyes, like in the midline in front of both eyes, sometimes called straight ahead. Okay, this is how the brain interprets the location, because it's not enough to see the object, color, dimension, every characteristics regarding the object. The brain needs to also give us an idea about the location. So we need to know the location of the object in front of us. So once the image is falling on the fovea, the brain will tell us that this object is centered in front of both eyes. Okay, and that's why sometimes we call the visual direction of the fovea is called the principal visual direction. All right. But remember, right now you are, for example, you are watching the screen of your mobile or laptop, but at the same time, there is a surrounding objects, and you still appreciate the surrounding objects because we have a visual field. It's not only one point of fixation, but we can watch the surrounding objects by the retinal periphery. Okay, so right now, imagine we have a banana here. The light rays from the banana will fall here on let's see here, in the nasal retina here, okay, and in the temporal retina here. Again, normally, these 2 points should be corresponding points in order for the brain to make fusion, because this is called fusion, because I need this image to be fused with this image in order to perceive this banana as a single. Okay, so single vision is not only for the point of fixation. I want to see the whole environment in front of me single. So again, we have like corresponding points. I hope you can notice now that if we have a point on the nasal retina here, its corresponding point is on the temporal retina here, and it's equidistant from the fovea. Okay, this is normal. A point here on the nasal retina has a corresponding point on the temporal retina. Okay, one more thing. We have something called, according to Kanisky, he used the term projection, but in some references, they use the word projection for other things. But anyhow, if we have an image falling on the temporal retina here, okay, the visual direction, the person will perceive this image as it is come off on the nasal field of this eye. So again, here, the image is falling on the temporal retina. It will be projected on the nasal side of this eye. So what is the nasal side of eye? Again, remember, this foveal direction is the reference point. So this area is the nasal, okay, of this eye, and this area is the temporal. So if the image is falling on the temporal retina, the direction or the visual direction of this image will be nasal, okay? Now apply the same to the other eye, the right eye here. Here the light rays fall on the nasal retina, so it will be projected temporally in this area, okay? And since we have normal ocular alignment here, these images are fused by the brain and interpreted to be coming from an object on the right side here, okay? Kanisky used the term projection. So if an object in this area falling on the nasal, it will be projected here temporal to this eye, and here is the image is falling on the temporal retina, it will be projected nasally in respect to this eye, okay? All right. So as you can see, I don't write too much text because I'm not good at writing text, but I'm good at drawing. So here, I think if you have read the first few pages of Kanisky, you will come across many terms and many definitions, and but what's really important is to keep this picture in your mind, in your, like, let's say, the mind's eye, because we have a better memory for pictures and for illustrations than for written words, okay? Today, we are going to talk about the sensory changes in strabismus, but I'm going to revise again what I said quickly. Normally, this person is looking at distance. The eyes are straight, like the visual axes are straight, but then there is an apple. So I'm repeating what I said. So what happened? Both eyes should be converging in order to see this apple, the image on, and to fall on the fovea. And the brain will fuse these images into single object, okay? And this is called, by the way, bifoveal fixation, because again, this is called the object of fixation or the point of fixation. And since we use the fovea in each eye and they are fused, this is called bifoveal fixation. So this is called bifoveal fixation. Because I used, or the person used the fovea of each eye. And what else? Normally, we have something called single binocular vision. What's the meaning of this? Any object in the physical space will be seen single, okay? And we have something else called stereoscopic or stereopsis. So it should be seen also in depth. But this is another topic. But this is normal, okay? And this also applies not only to the point of fixation. Every point surrounds the point of fixation because we have a visual field, and everything in the visual field should be seen single as well. Okay, let's move on. So I'm in today's class, I'm going to use like a smiley mouse like here to represent normal ocular alignment. Okay, so this is in simple. Okay, about what is the normal binocular single vision. We have fusion done by the brain. In order for the brain to make fusion, the image in each fovea, let's speak about the point of fixation, the image in each fovea should be similar, and we have normal correspondence. Both images are fused by the brain. We have single vision, and also we have something called stereopsis. Now, coming now to the onset of strabismus. So try now, we are going to tell a story about sensory changes in squint, and I'm trying to make it simple as I can. We have a lot of S's here. So once upon a time, there is this person, a happy face, okay, with normal ocular alignment, and he used to be an ortho, okay? And all of a sudden, he developed a manifest strabismus. To be specific, esotropia of his left eye. Okay? So he is going to suffer a lot of phenomena, visual phenomena, and today's class is all about this visual phenomenon. Back again to his past, when he has like a normal ocular alignment, and you're already familiar with this drawing, okay? So try to be focused because now we are going to show esotropia of the left eye. So what happened? The left eye is, so squint is all about rotation. So esotropia means this eye, the left eye is rotated inward, okay? Again, this is a normal ocular alignment. And now the left eye is rotated inward. And if you imagine, the visual axis of this eye is becoming convergence, and this is why it is called the convergent squint, because this visual axis is now becoming converging, okay? But here, the light ray from this apple now is falling on the nasal retina, or nasal to the fovea, because fovea is the reference point here, okay? So here, the apple's image, its retinal image on this eye is now falling nasal to the fovea. Yes, I agree. So Dr. Asad said, I have to say deviated. Okay, it's deviated inward, but in order to deviate, it should be rotate around the center of rotation, okay? But definitely abnormal. Let's say it's deviated inward, okay? So now the apple image on this eye is falling nasal to the fovea. Here is my question to you. If you are really observant, if you notice this image, the color is not as red as the other eye. Why? Why I drew this apple in that color? It's like washed out, like it changes the color. Okay. Okay, so the answer is fovea has the highest visual acuity and the highest color recognition and so on, all the functions, you know this better than me, of course. But here, any area away from the fovea, it would be like blurred. And now when I'm going to demonstrate diplopic image, the diplopic image is often not as sharp as the true image done by the or created by the fixating eye. By the way, this is called the fixating eye, and this is called the squinting eye. This is another term you have to be familiar with. So in this illustration, this eye is the fixating eye, because this is the normally aligned on that object, but this is called the squinting eye. Okay. So I drew the apple in a washed out color because to remind you that the diplopic image will be again will be blurred. Okay. All right. When we have an image nasal to the fovea, it will be perceived as coming from the temporal side. Okay. So in esotropia, let's summarize. So if we have an esotropia, an acquired esotropia in an old child or an adult, okay, the patient will see diplopia, okay? And since here the diplopic image is on the same side of the squinting eye, this is called uncrossed diplopia. This is called uncrossed diplopia. The person sees what, or the patient sees what in his visual space? He will see two images. One is sharp and straight ahead, like centered in front of his eyes, caused by the fovea of the fixating eye, because of the image falling on the fixating eye, and another blurred image on the same side of the affected eye, because it's created by an extra foveal area, okay? And this is uncrossed diplopia in a case of esotropia. And we can say it in a different way. For example, we have diplopia here. Why? Because here the light rays is falling on non-corresponding points, because this is the fovea and this extra foveal area. So we have here non-corresponding points, okay? So diplopia happens when an object stimulates non-corresponding points, because the fovea is not corresponding to this point. It's corresponding to this fovea. But because of misalignment, okay, or the deviation, we have an image here on the fovea and image here on non-corresponding point extra fovea. And that's why the patient sees double vision. All right. Again, this is an important term called fixating eye. And this is the squinting eye. So remember in the first class, I was like having some short discussion about the strabismus and squint, the terms. So squint could be a verb like squinting eye, but we can't say strabisming eye. Okay, so it's silly, I know, but we usually say squinting eye. So this is a kind of diplopic image. So try to discriminate between the word image, what the person or what the patient sees, and the retinal image, okay? So in some reference, you will find the term diplopic image or false image, okay? Because this is unreal. There is no object in this space, okay? This is the visual space. This is what the patient sees, okay? But this is not actually the location of the object. Okay, sometimes you will find a lot of definitions regarding diplopia. So we can also describe diplopia as what? One object perceived as two objects or two images, one object perceived as two images at different locations, because we have here one in the central and one on the other side. Okay, this could be another definition for diplopia. So here is my question. Give me a common example, okay, of an esotropia, like acquired esotropia, an important common example of acquired esotropia in an old child, or because usually when we are talking about diplopia, we are talking about an acquired strabismus. I will discuss this later in the next slide, in the next class. Okay, excellent. So the common example, we usually, when we are trying to give an example for esotropia, we usually say sixth nerve palsy. So sixth nerve supplies the lateral rectus muscle, which is responsible for abduction. So when you have a palsy, the lateral rectus muscle is not functioning well, okay, but the medial rectus is functioning well, which is called the antagonist muscle, pulling the globe inward. And sometimes you have to know this by heart. When you have a sixth nerve palsy, like or acquired esotropia in general, so we have a diplopia, and I said you have to say uncrossed diplopia, okay? Sometimes we classify diplopia into horizontal and vertical, okay? Here the images, the perceived images are like horizontally separated, so it's under the heading of horizontal diplopia. And when we are talking about diplopia caused by ocular misalignment, it's called binocular diplopia. Let's say it like quickly. When we have an ocular misalignment and diplopia due to ocular misalignment, the diplopia disappear on covering either eye. If you cover the right eye, the diplopia disappear. If you cover the left eye, the diplopic image disappear. All right, so this is an illustration for uncrossed diplopia in a case of esotropia. Let's discuss about the opposite. We have a happy face here. And what happens now? The left eye is deviated outward, okay? So this is a normal ocular alignment. And now we have exotropia. So here the left eye is deviated outward or rotated outward, okay? Once more. This is a normal. Focus now on this area. And here the eye is deviated outward. Okay, if you imagine the visual axis is like here, it's like diverging visual axis, and that's why the other name for exotropia is divergent squint. And now the light rays from this apple is falling what? Is falling where? On the temporal retina, temporal to the fovea, and it will be perceived nasally here on the nasal field. Okay, so we have here the diplopia, and this diplopia is called crossed diplopia because the affected eye is the left eye, but the diplopic image on the right side, on the right side of the object of fixation. Again, the object of fixation is the reference point because this is represents the straight head or central position. So when I say crossed diplopia, it means that it crosses to the other side of the object of fixation. Okay, so this is the illustration for exotropia. A common example for exotropia and crossed diplopia, if we have a decompensating exophoria. So if you know, exophoria is a kind of latent squint, but it is under control when both eyes are open. But sometimes we have a period or if the patient is exhausted or tired, sometimes it decompensates. So what's the meaning of decompensate? And instead of being exophoria, this is the symbol for exophoria, by the way, and it's decompensated into exotropia, into manifest. And this is the abbreviation for exotropia, okay? All right, so during the short periods of decompensation, so here I brought my avatar because I have exophoria. So I am myopic. And if you know, most myopics, when they are tired and exhausted and not wearing their glasses, they have exophoria, and it's easy to decompensate for a second, okay? So I appreciate crossed diplopia every now and then, okay? So just remember me on this slide, because this is a common example. And if you remember, this is why exophoric patients, if you remember from the first class, close one eye, shut down one eye, like squinting one eye when they are exposed to sunlight, okay, to avoid diplopia, crossed diplopia due to exotropia. Again, it's binocular and it's horizontal. Dr. Asad mentioned the example for palsy, third nerve palsy, but I didn't write it down because, you know, sometimes we have ptosis covering the eye and the patient doesn't appreciate the presence of diplopia, okay? So, but I wrote down this example because I'm speaking about myself, okay? So this is a summary of, this is uncrossed diplopia and esotropia, and this is crossed diplopia and exotropia. For those who like mnemonics, let's make a nice mnemonic here. So again, this is the abbreviation of exotropia. Remember, we are talking about a manifest strabismus. So all these slides about manifest strabismus, okay? Yeah. So if you, thank you, Dr. Roida. So extropia, so we have X. So it reminds you of crossed. So we have cross. We have cross. So X is crossed the letter. So we have a crossed diplopia. Okay? This is crossed. And now you can make the opposite. So in esotropia, it is uncrossed, of course. All right. In Kansky, I just checked the Kansky today. So he wrote homonymous for uncrossed and heteronymous for crossed. But I don't know, I don't like these terms because we usually use these terms for visual field defects, okay? So try to say crossed and uncrossed diplopia is the most commonly used terms for describing, you know, this kind of horizontal diplopia, okay? And again, by the way, the term crossed and uncrossed is applied only to horizontal diplopia, okay? Because right now we are going to show you vertical diplopia. So crossed and uncrossed is restricted to horizontal diplopia, in which exotropia causes crossed and esotropia causes what? Uncrossed diplopia. Now coming to vertical strabismus. I'm going to show you just one illustration for a case of hypertropia on the left eye. When it comes to vertical strabismus, you have to be careful about specifying which eye, okay? It's really important to say which eye is the hypertropic, for example, okay? So in this example, we have left hypertropia, left manifest hyperdeviation of the left eye. How can I demonstrate the diplopia in such a case? So back again to our happy face with normal ocular alignment. This kind of illustration is good for horizontal diplopia. In order to demonstrate vertical diplopia, we have to make some change, some tweak here in the illustration. What I mean by this? Okay, so we will draw the right eye above and the left eye below, okay? Here I changed the apple into another target because apple has like a leaf and it might be confusing in illustrating vertical diplopia. So I changed to a star, okay? So this is the normal ocular alignment, but I will use this illustration to demonstrate vertical diplopia. So this is a normal. You just imagine that you are viewing the person from above his head, like you are above the patient's head and viewing both eyes, okay? Now the left eye is deviated up. Have you noticed the left eye is deviated up? Because here is up and here is down, okay? Once more. Notice the left eye. I'm going to show you the left hyperdeviation or left hypertropia by making this kind of deviation or rotation. Now the light rays from this star is falling what? It's falling above the fovea. In projection or in visual direction, if the image is falling above the fovea, it will be perceived, okay, lower to the object of regard. So we have here vertical diplopia, okay? And if we have a hypertropia, the diplopic image is lower. The false image is lower, okay? So it's against the deviation. So again, the object here is falling, its image is falling above the fovea. So if you have a hypertropia, the image is above the fovea, but it's perceived lower, Okay, so we have the diplopic image is lower. Clear now? All right. Give me an example, an important example, maybe common example of a vertical diplopia, to be precise, like hypertropia, acquired hypertropia, and it's a very important topic and commonly asked in the exam. Yeah, exactly. So we have, forced nerve palsy, acquired forced nerve palsy, or we can say also decompensated congenital nerve forced nerve palsy, but make it simple, forced nerve palsy. So I wrote here binocular because we are talking about ocular misalignment. So this is a kind of binocular diplopia. Okay, if you cover each eye or either eye, the diplopic image will disappear, or the patient will see single, and it's kind of vertical. The patient will see the object of fixation in the central location, and the other image will be, the false image will be lower, okay? And of course, this is diplopia. Here, this is my question for you. I made a blank here. In reference to forced nerve palsy, yeah, exactly, Dr. Fabian. So we have also torsional components, but we are not going to demonstrate torsional diplopia. So, but you have to keep in your mind that in forced nerve palsy, it's not only vertical diplopia, but also torsional diplopia. Sometimes the torsional component is more important than the vertical component, because this, if you remember, superior oblique muscle is the main function of superior oblique is in torsional function. All right. I finished my talk about diplopia, but here I want to change the title of my presentation, because you will never find this title in any book, sensory changes in strabismus. But I was trying to make it simple. But now I will make it accurate. So instead of sensory changes, okay, so we can, instead of sensory changes, we can say visual phenomena with the onset of strabismus. Okay, because diplopia is something seen, okay, something perceived by the patient, and of course something visual, okay, so it's a visual phenomena. But you know, phenomena is a plural, not phenomenon. So there must be another phenomena that I'm going to show you in the next slide. But and at that point, sensory change is an accurate title. You can say visual phenomena, or we can say visual perception. Okay. And also we can say something else, abnormal binocular vision. The last one is, you will find it in most references, because the examiner may ask you this question: what are the abnormal phenomena or abnormalities of the binocular vision? Okay, so the question again, what are the abnormalities of binocular vision? Because normally it's single and stereoscopic vision, but what are the abnormalities of binocular vision? Number one is diplopia, and we have another phenomena I'm going to show you right now, okay? Now I'm going to show the other phenomenon. So now we focus about the fovea of the squinting eye, the deviated eye. Actually, the fovea of the squinting eye, there is an object in the field, there is an object in the physical field, okay? The right rays comes from it, is falling on the fovea of the squinting eye, okay? Now we are focusing, or now we are discussing about what's happening in the fovea of the misaligned eye or the deviated eye. Actually, there is an image on the fovea of misaligned eye to an object in the on the physical space. Okay. Now, what is the end result? The end result is that we have an object, which is here the apple on the fovea of the fixating eye, but we have a black square on the fovea of misaligned eye. Okay. But since we have different images, totally different images, the brain can't fuse different images, you know. If you remember, normally the brain can fuse the image from the fovea, from each fovea, if they are similar. But here we have like different objects, different images are falling on the fovea. Okay, so this is not a fusion. There is no fusion in this case, but we will get something called confusion. According to Kanisky, because right now I'm following Kanisky, because Kanisky, we love Kanisky and it's very simple, okay? But sometimes is regarding this slide, it's not totally accurate. But to make the concept simple, he drew the confusion. This is called confusion, by the way, like this. But in reality, the brain can't fuse two different images like this, okay? So this phenomena is called confusion. And since we are talking about visual phenomena, the full name is visual confusion. But sometimes we say confusion for short, okay? So what's the meaning of confusion? Let's define confusion together. Watch this small square. We have two objects, okay? Two images are falling, two different images are falling on the fovea, okay? But they are perceived at the same location. Why? Because the brain, whenever the brain gets an image on the fovea, this means that this object should be directed straight ahead, okay? So whenever the brain got an impulses, like stimulation from the fovea, it will be interpreted as if it is coming straight ahead, okay? So the black square will be perceived here, despite the fact it's here on the side. But since it's falling on the fovea and the fovea have a central visual direction, it will be perceived to the patient as central, like as a straight ahead black square. Besides, we have the apple, which is created by the image of the fixating on. So it's not really a fusion, but it's kind of confusion because we have two different objects, two different images. All right. But in practice, some claim that it's never going to be happen, okay? Because usually this image is suppressed by the brain. So generally, we will talk about this in the next class. So this area, this fovea is suppressed by the brain. So mostly no patients will complain. So patients don't complain about confusion. They do complain of diplopia. Again, patients don't complain of confusion. They do complain of diplopia, okay? Because this is of little importance in practice, I keep it the last slide, actually, in my presentation. So in order to like give a definition for confusion, we have simultaneous perception of two different images in one location. And this slide summarizes all the two visual phenomena, diplopia and the confusion in a case of esotropia, okay? In Kanisky, he wrote pathological diplopia. We don't need to say pathological diplopia, but actually there is something called physiological diplopia. If you are interested, you can search for it. But it's really enough if you are asked about the abnormalities of binocular vision, you can say diplopia and confusion. If you want to sound more professional, you can say pathological diplopia and visual confusion. Okay, but don't say pathological diplopia, because if you say this to me, I will ask you, my next question will be, tell me about the physiological diplopia. So don't let yourself into troubles or anything. Just say diplopia. And to be precise, you can say binocular diplopia. Okay, and you can specify, like in this case, uncrossed diplopia. So actually, the most important part in this presentation is the illustration for diplopia. Diplopia is an important sign. Here I put the red flag because sometimes it's a red flag sign, and you have to take it seriously whenever the patient is complaining from diplopia, especially acquired acute diplopia. Okay. So again, in order to ignore this title, and the better title is abnormal binocular vision. All right. Now, quiz time. This is a single best answer. Okay, so a patient is complaining from double vision. On covering his right eye, he sees single. So he has binocular diplopia, he has uniocular diplopia right eye, he has uniocular diplopia left eye, and can't decide on the type of the diplopia. So I didn't talk about uniocular diplopia, but since you are advanced learners, so you can answer it easily. Yeah, I got the right answer finally. So the right answer is D. Okay. In order to diagnose binocular diplopia, it's not enough to cover one eye. Okay. It's not enough to cover one eye. So imagine now this patient has esotropia and he has double vision. So in order to verify, you have to cover, let's say, the left eye, and the patient will say, I'm seeing single now. And then you have to cover the right eye, and you ask the patient will say, I'm seeing single now. So the definition of binocular diplopia is diplopia that disappear on covering either eye. Okay. Back to the question, because now try to remember, if the patient has like, let's say, what are the causes of monocular diplopia, by the way? What are some of the causes of monocular diplopia or uniocular diplopia? Yeah, could be another cause. Yeah, I like ectopia lentis. Let's focus on ectopia lentis because we have area is aphakic and area is aphakic. This might create a kind of diplopia. So imagine now we have like lens subluxation in the right eye. Okay, patient is seeing double. So once you cover the right eye, the double vision disappears, right? So actually, at this point, it could be monocular uniocular diplopia due to problem in the right eye. Okay, so it's not enough to cover one eye. You have to cover each eye in succession in order to confirm the presence of binocular diplopia. Actually, in practice, in practice, when the patient's complaint is double vision, during history taking, we ask the patient to do this by himself or by herself. So suppose that I have a patient right now. The patient says, I have double vision. So while I'm taking the history, I actually ask him, close your right eye, do you see single? Close your left eye, do you see single? So while taking a history, I can have an idea about it is binocular or uniocular, okay? So usually we do this during history taking, okay? Actually, although it is a clinical test, but since it depends on patient's own words, we usually do it while history taking. I think you got my message, okay? So usually we do this during history taking. This is the bottom line here. Another quiz question, okay? Fill in the gaps. An adult patient with an acute onset of double vision, what are some of the possible symptoms or complaints? I know it's not a clear question, but let's answer the first one. Patient with double vision may complain of double vision. Okay, doctor, I'm seeing double. So this is number one, double vision or diplopia. Yeah, I got the answer. So, so the next one is blurred vision. So here, this is my message. Sometimes patient has like ocular misalignment, but they don't say I'm seeing double. They say my vision is blurred. Is blurring or blurring, okay? And usually this happens with small angle of deviation, because if you have a small angle of deviation, the diplopic image, the false image, is very close to the image created by the fixating eye. So some patients perceive it as a blurry vision, okay? So you have to be careful, okay? Sometimes the diplopic patient presents with this complaint, blurry vision. What else? The other symptoms is squinting. Sometimes the patient is entering the clinic, squinting one eye or closing one eye in order to avoid diplopia. And usually they close if we are talking about paralysis or restrictive, usually we are talking about acquired paralytic squint, usually they close the paralyzed side. Sometimes, okay? So these are some of the possible symptoms that are related to diplopia. The patient may complain of diplopia, like double vision. Doctor, I'm seeing double, everything is double, or blurred vision, or like an initial symptom, the patient, you can pick this sign on the patient, like entering the clinic, the patient is squeezing or like squinting one eye, closing one eye. Yeah, finally. So another cube is added to the previous one. Thank you all for your attention and for your patience. Supposedly, the next class will be about another big title. Actually, this was asked in the exam, in the FRCS exam, sensory adaptations to strabismus. Okay, so please notice here we have S because we have more than one thing. So sensory adaptations to strabismus. Okay. According to one experience, there was another question about motor adaptation to strabismus. So motor adaptation is singular, so it's only one motor adaptation. So we have sensory adaptations, our next class topic, and we have motor adaptation. It's not my next class or any class topic, okay? So we have a second part for our story, okay? Because there is a difference between a question about abnormalities of binocular vision, which is diplopia and confusion, and another question about sensory adaptations to strabismus. We can't allow this patient to suffer, okay? There is some mechanism to alleviate his suffering. Please don't forget to post the most important, sentence you liked in today's class. Until then, have a good day and happy studying, happy learning. I shall end the presentation right now. Any questions before I go? Thank you once more. Bye-bye.